Evening, everyone. Good evening, and welcome to tonight's Rehab Roundtable. Thank you all for joining us. For those of you who are new here, Rehab Roundtable is a monthly series hosted by AOCPMR. The goal is to promote academic engagement and foster meaningful conversation around the latest research in physical medicine and rehab, specifically through the lens of justice, equity, diversity, and inclusion, or JEDI. Each session centers on a specific JEDI-related theme, so we can really dig into the critical topics shaping our field. And if you're interested in speaking at a future event, I'll be putting the link in the chat later on. I'm also very pleased to introduce tonight's moderating physician, Dr. Kelley Ingram. Dr. Ingram completed her medical education at Pacific Northwest University College of Osteopathic Medicine and is currently a PGY2 in Physical Medicine and Rehab at St. Luke's. Her clinical interests within PM&R include sports medicine and brain injury, and we look forward to hearing her insight. Tonight's topic is sex and gender-based disparities in the use and prescription of mobility assistance devices, and we'll be hearing from a couple incredible medical student speakers. With that, I'll hand things over to Aya.
Oh my goodness, incredible medical student speakers. I I feel like the bar is very high, so I appreciate it. So, like Simran said, my name is Aya. I am actually the one of the incoming co-chairs for the JEDI committee, so that's why I am very excited to be here today. And I go to Michigan State College of Osteopathic Medicine, where I am a second year student. And today I will be presenting about an article titled Exploring Sex Differences in the Needs and Priorities of People with Lower Limb Amputations and Adaptations of the Prosthesis Evaluation Questionnaire. So, a couple of terms before we get started. I'm going to be referring to these, so I wanted to sort of clear the air. So, PLLA stands for Person with a Lower Limb Amputation. You'll be hearing that quite a bit right now. We also are going to be talking about the word sex. So, that refers to biological and physiological attributes that are typically categorized as male or female. And then you'll also hear the term patient-oriented research, so POR for short. And that essentially is this really great way of doing research where it approaches individuals who have actually had those lived experiences and asking them what their priorities are and using that to inform the research. So, a little bit of background, why does this matter so much? Well, that's because there's this incredible, I mean, it's not incredible in a good way, but there's this very stark underrepresentation of females with lower limb amputations in prosthesis and gait research. So essentially, there's about 30% of all PLLAs are female. But for example, only less than 10% of gait study samples are female. So that's what's used to inform a lot of the prosthetic research field and how prosthetics are made. So you're really not getting that much input from such a large fraction of the PLLA population. And that's important, especially because females do have unique challenges. So the research does show females having a higher risk of osteoarthritis, fall-related injury, challenges with mobility, and just in general, less satisfaction, less success with prosthetic fit, and they often reject their prosthetics more than males do. And right now, there are some questionnaires that exist. So questionnaires, right, surveys. They do exist to ask PLLAs how their experiences are and their satisfaction is, but they don't really cover anything that is sex or gender specific. They're not really trying to parse out what are the specific needs of female PLLAs and their experiences. So that's when it was made very clear that there is a need for female-informed research and to create a new tool to figure out what the needs of female PLLAs are. And that brings us to the study's objective. So this article really focused on using patient-oriented research or POR methods in order to adapt an already validated questionnaire. So you might have heard of it. It's called the Prosthesis Evaluation Questionnaire. And they adapted it to better discover what are the sex differences between different groups of PLLAs using their perspectives and priorities. So how did this design work? How did the study work? So it was a cross-sectional study. It was basically this online questionnaire that got sent out to a certain group of individuals. And this questionnaire was made by this awesome group of 2 researchers, as well as 5 females with lower limb amputations. So essentially what they did is they got together and discussed what are some high priority topics for specifically female with lower limb amputations, and how can we adapt this questionnaire to fit those priorities? So in the end, they ended up with a 86 question online questionnaire. It was a mix of open and closed questions, which I think was really great because we're going to talk about really getting to hear participants' voices with those open-ended questions. And then obviously there was an analysis done at the end. So we will talk about that. When they were choosing their participants, essentially, this was a study that took place in Canada. So these were English-speaking Canadian adults. They had unilateral transtibial or transfemoral amputations. It had to have been at least 1 year after their amputations, and they had to have a functional classification level above 2. And also, they kept an eye on confounding variables, other factors that could affect walking ability, things like severe depression or pregnancy. And in the end, they had a group of 26 participants. So it was pretty split down the middle with 13 males and 13 females, and they had a good diverse group that way. So I'm honestly not sure if you can see or read any of this, but these are two screenshots that I took of the actual questionnaire. So you can kind of see there are questions about well-being, satisfaction with the prosthetic, pain with their prostheses. So again, it's a mix of rating things from 1 to 10 or being able to actually answer in their own voices. So I broke down the results of the questionnaire with kind of the three main categories of findings. One of them was with ambulation. I don't know why it's doing that, but one of them is with ambulation. So essentially, females had reported significantly worse ambulation than males. So the lower the score was, the worse their ambulation level was. And there was definitely a clear difference between being able to walk up a steep hill and also down a steep hill. So we're going to jump into this more a little bit later, but that was a significant difference. There's also a significant difference with the social burden that both male and female PLLAs experience. So females, again, with the lower score, had a greater burden that they perceived socially. So these are like emotional aspects, challenges that they face in public because of their prosthetic. And then lastly, what the questionnaire really aimed to look into were sex-specific differences. So this was brand new, where they found that there was an effect of the prosthetic, of the lower limb prosthesis on the interest of having children among males and females. So males actually reported no effect on their interest in having children because of their prosthetic, but females did. And a little bit more into this. So something interesting was that this study, unlike a lot of other studies across the literature, the study didn't find any sex differences necessarily between male and females for prosthesis satisfaction, fit, or comfort based on their closed questions of how satisfied are you from 1 to 10. But what's interesting is that males in general had a trend of when they were asked what could be done to improve your satisfaction with your prosthetic, they usually wanted more function. So I want to be able to flex the ankle more, a greater range of motion, and things like that. While females usually more often wanted better prosthetic fit. So for the fit to be more comfortable, for the weight to be easier to move around in. And then some other trends that I found very interesting, but weren't necessarily statistically significant, were that females had lower appearance scores when it came to how they looked with their prosthetic than males, and also they reported more clothing damage from their prosthesis. So these are things that also could affect their satisfaction with their lower limb prosthetic. So diving in a little bit more, we did talk about the physical factors that affected females with lower limb amputation. So yes, they reported lower scores in ambulation, and that did mirror what a lot of the literature says, that in general, females do report poor ambulation ability. And the interesting finding was that, again, sloped walking, just in general, I think a lot of people on this call have noticed that it is harder to walk up or down a hill than it is on level ground. So with a lower limb prosthetic, you can sort of understand that it is more difficult to do that. But again, this is a finding that it could be due to other sex differences. Maybe it's biomechanics, maybe it's a muscle strength issue, but definitely more research needs to be done in that sense. And now diving into the psychosocial aspects of the lives of people with lower limb amputation. So we talked about females having a greater perceived social burden because of their prosthetic. So we talked about their interest in having children. So this was something that, again, with the open-ended questions in the questionnaire, females were able to voice their concerns about. And a lot of them voiced concerns about not having enough energy or it not being safe to have children or not being able to meet the physical demands of pregnancy and raising a child. So a direct quote from one of the participants was of her concern of the extra pressure carrying around another human would put on my residual limb. So again, this is something that was only found among females with lower limb amputations. And that could be something that could have caused that significantly greater perceived social burden that we saw in females earlier in this presentation. There's also the idea of femininity and masculinity being affected by having a prosthetic limb, and also the stigma that comes around with it. So unfortunately, stigma still exists, and it is something that both the male and female participants did report. They did report that there was a stigma by being an amputee, and that negatively impacted them. But when they were asked to sort of explain more about that, only the female participants were able to describe sex-specific challenges. For example, there were quote unquote, there were never female role model amputees in mainstream society, is what one participant wrote. And another participant says, often male amputees can be viewed as strong, whereas female amputees don't get that same response. So these are things, again, that can really increase that social burden on females with lower limb amputations, and you can kind of see that this is female specific. Okay, so just some limitations of this study. We did notice it is a smaller sample size. It was in Canada as well. It's not here in the US. And there were also some non-validated questions in the questionnaire, which means that they didn't go through the rigorous scientific process that the rest of the questions did. And then something I found interesting too was that there uh, wasn't much data that was gathered about the backgrounds of the participants regarding pregnancy, if they've ever been pregnant before, if they were experiencing menopause, close to it or far away from it. So these were things that you would think maybe would have also an effect on the conclusion. So to wrap this up, we definitely did see sex differences in prosthetic needs and abilities and priorities among different people with lower limb amputations. And there definitely is a need for research that is focused on this. And in the future, we really hope to see a larger sample, even more diverse, and research studies that also explore what effects to pregnancy, menopause, just other factors have on these responses that we're seeing in the questionnaire and in their satisfaction with the prosthetic that they have. And then also that interesting finding about sloped gait. So this was something that the article really focused on, as well as it kind of being a little bit more of a novel finding. So it would be interesting to see more about that. And that wraps up my presentation. So I want to thank you all for listening. I think we're leaving questions towards the end, but Dr. Ingram, if you have any questions or comments, we're happy to field them now.
This was a perfect article for this month. I don't know if you know that it's actually Limb Loss Awareness Month, April. So this was a perfect selection for that. You brought up a lot of really great points, especially regarding females and research just in general. They're highly underrepresented, especially in the limb loss community. And, this brings up great points about females and the physiological changes during pregnancy with use of prosthetics, because the body's going through dramatic changes, weight loss, weight gain, edema throughout a 10-month span. And that makes fitting and use of prosthetics really difficult. So I think this was a great article.
Thank you so much.
All right, I think it's my turn. So my name is Nathaniel Teplitskiy. I am the other co-chair with Aya for the JEDI committee. So thank you so much for having me here today. I'm super excited to present on this topic. So my article is about gender differences in mobility device use among US adults. And I'm OMS-II at TCOM down in Texas. So just presentation outline, going over the introduction, methods, results, discussion, and considerations. And so why this topic? So first, mobility limitation is usually the first sign of late life functional decline. And so mobility devices specifically mitigate the disablement process, and cane use may signal an earlier phase of disablement. So why canes specifically? Well, canes typically are used at the earlier stage of their mobility limitation, and its use can prevent further loss or damage to the joints, improve gait symmetry, and add support and stability, as falls tend to occur when the owner is not using the device. So women are more likely than men to develop mobility limitations in later life. So the purpose of this study was to examine the influence of gender and other factors on the use of mobility assistive devices, specifically canes. And the hypotheses were gender differences in the likelihood of using canes may be explained by health conditions, impairments, and capacity limitations. So more kind of your physical um, variables, but also the gender differences in the use of canes beyond those may be explained by behavioral, psychosocial, and social environmental factors. So the methods, so this was based on the National Health and Aging Trends Study, or NHATS. Um, It was NHATS is a nationally representative sample of adults greater than 65 years old from Medicare enrollment databases, the Medicare enrollment database. And so the NHATS investigators initially conducted 8,200 in-person interviews. The study investigators excluded nursing home residents, as well as participants that did not complete their interviews. And so that left with about 5,500 or so, with 1,100 arcane users. And also forgot to mention that those that were excluded were those that only used a mobility device besides a cane. So the measures, so the main outcome variable was cane usage. The primary variable was gender. So in this article, it's a bit older. They refer to gender as just male and female. So I just wanted to acknowledge that. And they separated the rest of the variables into 6 covariate blocks. Um, First one being sociodemographics, health conditions, physical impairments, limits to physical and mental capacity, psychosocial factors, and social environmental factors. So this paper is a little more stats heavy, so please bear with me. I know it's our favorite thing. But they did do some bivariate analyses and a hierarchical logistic regression, kind of evaluating these models to kind of predict what variables will likely increase or decrease the use of canes among women. So just in general, this is part of table 1. So women significantly were more likely to be older, lower income, and had less formal education, and were enrolled in Medicaid based on the NHATS study population. There were no significant differences in self-rated health, falls, or hospitalizations. Women reported significantly higher blood pressure, arthritis, osteoporosis, hip fracture, and obesity. And in general, women reported also significantly increased impairment, physical impairment. Women also reported increased depression, and they used the PHQ-2 for this, and also fall worry. And there's also had significantly larger social networks, but they also tend to live a little more alone or in a retirement community. And women were more significantly likely to receive mobility help instead of using a device. So the bulk of the paper was going over these models. And so just general trends were that initially women were more likely to use canes. So model 1, which is just the demographics, so race, ethnicity, um, income status as well. But gender differences decreased and became non-significant when adjusting for health, impairments, and capacity, which are models 2 through 4. They remain non-significant when adjusting for psychosocial factors, but they became significant less cane usage among women when fully adjusted. I'll go into a little more detail about each of those in a second. But in general, the initial raw rate of cane usage among women is higher, but when adjusting for all these factors, it decreases significantly. So the first model had a pretty good discriminative ability. Some other variables that were considered, so being a Black individual had an increased odds of using cane usage, being on Medicaid or higher income. As far as health, many different conditions were associated with an increased cane use. So poor health, poor self-rated health, arthritis, osteoporosis, diabetes, obesity. Also recent falls and hospitalizations were a significant predictor. Model 3, they looked at impairments, specifically pain, energy, balance, upper and lower body limitations. For model 4, looking at capacity, was the physical performance. And again, also had a pretty strong discriminative ability. And for Model 5, psychosocial, um, the most significant variables affecting or impacting cane usage was fall worries and self-realization. And for Model 5 specifically, they use a theory of planned behavior. For those who don't know, it's based on the attitudes, norms, perceived control of using or of a behavior. And then for Model 6, after controlling for all environment, social factors, so receiving mobility help and living alone were the greatest predictors of increased cane use. Okay. They also found a couple moderators. So for example, if you had poor health, self-rated poor health, and were female, you had less likely use of canes. Um, Same thing with balance problems. Obesity had the opposite trend. And if you'll notice on the graph, it's somewhat similar trend for obesity among genders, but balance and poor health perception kind of track with women using canes less. So just as a quick discussion, so many factors go into why or who, so who and why people use or don't use canes. It suggests that underlying health differences partly explain observed usage patterns, but do not fully account for them. So as I mentioned before, women have higher raw rates of cane use, but are significantly less likely to use canes when accounting for health, function, and other social factors. Those physical variables help explain observed higher uses, but again, don't fully account for them. Of course, health status and impairments interact differently among men and women. And environmental factors, such as living alone or retirement community, may impact the disablement process and may be determinants of health behavior. And in this case, cane use. And so cane use may be more discretionary versus a walker, which I forgot to mention. They did a sensitivity analysis and found that walker use is more associated with physical necessity versus other social factors. Looking at kind of the more psychosocial, behavioral, and social environmental factors. So environmental factors actually suppress the relationship between gender and cane use. Psychosocial and behavioral factors may influence those decisions to use the canes. But in general, using a cane is a very complex personal negotiation, usually involving the idea of aging and being vulnerable for older adults. Just some limitations. So this was actually a cross-sectional design, so you can't really infer causality. They didn't fully evaluate the theory of planned behavior constructs. They also did not really consider other ethnic and cultural considerations. For example, for the race ethnicity variable, they only looked at non-Hispanic whites, non-Hispanic Black, and Hispanic groups. Again, given the nature of the study, they focused on relatively healthier subset of older Americans. And so just some considerations for the future. It's really important to assess functional need early, promote clinician involvement, especially because cane use can enhance independence and are more effective than personal help. It's also important to address psychosocial and gender-specific barriers and making sure to incorporate those social context and cultural factors in that decision. As I mentioned before, there is a much greater need for women in research. And so ensuring adequate representation in research, particularly in the context of living alone and receiving mobility help for canes, is important. And then also encouraging the appropriate device use over personal assistance when beneficial, while acknowledging the stigma associated with cane use. And that is it. Thank you guys so much.
That was awesome. I think that's something that we in rehab setting don't necessarily think about all that often because we rely a lot on our OT and PT partners to really come up with those prescriptions for assistive devices. But it's really something to think about and kind of bring to the forefront. So good job selecting that one.
All right. I'm going to go ahead and round us off. Okay, awesome. So my name is Kirthi, and I'm currently a second year at MSU Com. And today, the article that I chose is going to be focusing on a more general scope of the effects of sex and gender within rehabilitation outcomes and the representation or misrepresentation of those effects. So, in general, across the globe, there is a very large scale unmet need for rehabilitation. And while we do understand in general how sex and gender interact on a larger scale in order to act as social determinants of health across a larger health system, there is a lot less research about how that particularly affects the field of rehabilitation and what those disparities look like in terms of rehabilitation access, use, adherence, and outcomes. And this study was a literature review, and it aimed to explore the impact of sex and gender and their interactions with different socioeconomic variables and structural factors on the rehabilitation, participation, and outcomes across different sex and genders. So in general, this literature review focused on articles across a 15-year span, focusing on starting from the mid-2000s and 15 years after that. So they used three databases, and they essentially did this by looking at the mesh categories, which is a way to categorize the articles within the database, including different variations of sex-related terms, so including boy, girl, man, woman, intersex, gender disparity, gender bias, and terms like that, in combination with specific rehabilitation and assistive technology related terms, including rehabilitation, therapy, and assistive technology. And additionally, the search focused on both high income countries and low and middle income countries because they wanted to gain a broader understanding of how that research relates to gender and rehabilitation globally. And they did go into it with the understanding that there was probably going to be a lower representation coming from lower and middle income countries, and especially because this study focused particularly on articles written in English. So they did go into it with the understanding that that was going to be a lower representation, but accounted for that as well. So in terms of the methods, in particular for selecting the articles that were going to be reviewed, 65 articles in total were found out of the total of almost 5,000. And they were able to narrow it down based on three specific criteria. So they went through these three criteria twice, yielding 2 rounds that were able to yield these 65 articles. So the first was a specific focus on physical rehab or post-rehab functioning. The second was that it had to clearly articulate sex and or gender differences related to participation. And the third was that it was not focused on sex and gender differences specifically within burdens of disease, as they wanted to focus on the participation and the outcomes in particular. So what this found was that in comparison to men, women in general carried a greater burden when it came to rehabilitation outcomes and participation. They had lower rates of access, use, and adherence. And there were various socioeconomic factors that played into this. Some of them that were discussed in the other 2 presentations, like marital status, like lower levels of education, higher likelihood of living alone, and older age. And in addition to this, there was also a generally higher social and domestic burden on women, and higher caretaking responsibilities within the family. And in addition to this, women's participation in rehab was more likely to be impacted negatively by factors directly coming from the healthcare system. So women were less likely to get a referral from a healthcare provider to rehabilitation. And they were also less likely to have adequate insurance, as well as an adequate assessment, basically showing their need for rehabilitation. So in general, this article also did dive into a few subcategories. So in terms of psychosocial measures of improvement, Women showed similar improvement, but with a caveat, which was that the studies that were exploring psychosocial differences, excuse me, were actually showing mixed results. So there were some studies showing that women did actually have better outcomes, and some studies showing that men had better outcomes. And there were also other studies that showed that there wasn't sufficient data to show a correlation. So overall, the trend was that it was mixed results. And in particular, a factor that may have contributed to this, that the authors noted, was that there are societal differences in terms of how men are likely to express their emotions, and therefore they have a lower likelihood of being diagnosed with a mental health condition or any mental health issues being picked up. Um, and women also ended up showing less improvement in terms of physical and functional markers. While this was the trend overall, there were specific functional subareas that women did experience better outcomes, and this was specifically within specific categories of post-stroke rehabilitation and degenerative spine disease rehabilitation, in which women were shown to reach markers of independence closer to discharge than men were. And as for assistive technology, including mobility devices, women were shown to use more forms of them overall in high-income countries, but the trend was reversed in low-income countries. And in specific for assistive technology, women were shown to use mobility and vision devices more than men, and men utilize hearing devices more. But although women did have higher rates of utilizing assistive devices, they also were more likely to report an unmet need for these devices. And lastly, this did also focus on the disparities between men and women as caregivers, as opposed to solely as patients. And as caregivers within rehabilitation, women were also more likely to report a lower quality of life and a higher caregiver burden. So a really important result that I want to highlight here as well was that sex and gender were not very adequately represented as a spectrum within these articles. The majority of these articles were found to focus on these outcomes as a binary, so between men and women. So there wasn't really sufficient information to be able to compare rehabilitation participation and outcomes for populations outside of the binary. And in addition, there was also limited research in non-cardiac rehabilitation among the pediatric population and in low and middle income countries. So overall, this research reached the conclusion that there is a documentation of a basic disparity existing across many categories in rehabilitation across women and men, but there is still a need for research focusing on exactly why, and there was not sufficient research documenting the specific effects of sex and gender as a social construct. And moreover, a lot of these articles incorrectly conflated sex and gender. So this has created a need for documenting any disparities in populations such as the transgender population, the non-binary population, and the intersex population, as their experiences were either lumped into the binary or just completely obscured. And this also did lead to a false conclusion that these disparities are solely due to biological factors, when in reality, it's more likely either almost completely social or a combination of social and biological. And lastly, in terms of caregiving in particular, literature on caregiving tended to focus on heteronormative roles, whereas there was not much representation of non-spousal caregivers that tend to exist in non-heteronormative contexts. So as for where research should go from here, future research ideally should focus on investigating how sex and gender affect rehabilitation population and outcomes, not only in populations that are underrepresented, but also in settings that are underrepresented, such as the types of rehabilitation. So earlier we discussed that non-cardiac rehabilitation was underrepresented, and the research had actually found that musculoskeletal research was in particular lacking in proportion to the amount of rehabilitation that men and women both seek out in terms of musculoskeletal care. And in particular for low and middle income countries, this could particularly be something that was addressed with one of the limitations that this study had found, which was that they had only looked at English literature, but by also expanding that search outside of just English articles, they could potentially get more data on what that disparity looks like with low and middle income countries. So overall, unfortunately, they did not end up addressing the question that they had set out to answer, but this still did highlight some very important existing disparities, and health systems can still use this information in order to provide care that is person-centered and gender responsive and gender inclusive, in order to work to reduce the disparities that are known in terms of access and outcomes. And that is all. Thank you so much.
Awesome. Thank you for presenting that one. That was great. I think, again, that's not something that we frequently consider in rehab. It's not something that's always at the forefront of our mind, but just anecdotally, and I don't have any, data to necessarily back this, but I think in patients that I've seen working in rehab so far, particularly in the female population, we have patients that are pushing to go home earlier, maybe before we think they're necessarily ready, because they're concerned about a loved one or, really stepping into a caregiver role when they need to have that situation flipped. So definitely finding more support and identifying those gender and social role gaps is really important. So thank you for presenting that one.
So now we'll open up the floor to questions. If anyone is comfortable with unmuting their mic or putting your questions in the chat, we can kind of field it that way.
So I'm just going to start us off, but please go ahead. I love this topic so much. And excuse the background change. I had really bad Wi-Fi. So anyways, Dr. Ingram, I was curious because, and you kind of touched on this just now, with all the things that we're seeing stats on, what are kind of the biggest sex and gender issues that you're seeing in rehab? And especially, I think Kirthi was talking about, and I found it interesting, was that women usually were referred to rehab less often. I'm just curious, do you see that? What are some reasons behind that you think? Might explain it.
Yeah, that's an excellent question. I'll try and touch on all the points, but if I miss something, please stop me and I'll fill in. But I actually didn't know that women were being referred less often. So that's really something to think about in the future, especially when I move on to our consult service and we're recommending patients to come to rehab. But I think some of the biggest things that have been touched on in this discussion already is there's just not enough research out there, especially in the female population. I see this a lot, particularly in the brain injury community, where a lot of the studies have been done on males and of the kind of either senior group or, that younger early adult. I apologize if you guys can hear my cat in the background. There's just not a lot of research out there. And so I think more research needs to be dedicated to either comparing males and females or, outside of the binary, preferably both, or, just having more information that we can provide better care to our patients. And then kind of like I touched on a minute ago, I have seen patients wanting to go home earlier to support their families at home. They're more concerned more frequently with the family around them and their social system than sometimes their own rehab.
Thank you for answering that. That really gives good insight. So I appreciate it.
I had a question. Anyone can answer this, the presenters or Dr. Ingram. But what does social burden mean, and how can we navigate those conversations with patients to show them that we're understanding of those societal hurdles that they're facing?
Are there anything from the presenters that they found in their research that they wanted to touch on with that question before I answer from my point of view?
So I will just jump in real quick because that is a term that was used in the article that I looked into, and they sort of just talked about social burdens being as just extra sort of psychological or emotional issues that they felt came up because of their just general condition. So in social situations, basically.
Great. Thank you for that. I completely agree. That's my understanding of it as well. And I think to answer your question on how how to approach patients or how to make sure that we're all kind of on the same page, I think it's really good to, when you can, get a good social history and not just, the typical like, do you smoke? Do you drink? That kind of stuff. But who do you live with at home? What's their health like? Do you have family in the area? What is your social support system around that? Do you have hobbies? Are there things you're concerned about going home or things that you're concerned about staying in rehab? Just getting an idea of everything that can be contributing to it. I've had patients that are concerned because they have a pet that they left with a family member and they want to make sure that they're taken care of. So just focusing on what's important to the patient in that moment can kind of get them moved through the rehab process a little easier, I think.
I will actually also say that within the research that I looked at in particular, there was something really interesting that stood out to me, which was that the social burden actually looks very different for each individual, but in the sense that something that may be a deterrent to accessing rehab for one person could actually be a facilitator for another person. So that was something really interesting that this article had touched on that I think kind of also answers your question.
Yeah, if I can jump into, I think similar thing for my article, really the idea is to evaluate that individual as much as they can for all those factors and also the kind of stigma associated with use of mobility devices or other rehab practices.
Thank you
Exactly.
all.
Yeah. Looks like there is a question in the chat. I'll just read it out. What's the average amount of time you have with a patient, and how can you prioritize getting a good social history that pertains to the patient while also managing your time? I think that's a fantastic question because I'm sure, as you guys have heard, we are very limited on our time when we're seeing patients, and you guys will experience this if you haven't gotten into clinicals already. But it's a little different when you're in an inpatient setting versus an outpatient setting. Inpatient, unless there's structured things that are going on around it, you have a lot more time that you can spend with the patient and kind of drop in throughout the day rather than just doing everything at one time in the morning, like on rounds. Outpatient settings can be a little different. You're kind of constrained. And I think one way that I open up that conversation is just asking, what's important to you while you're here at rehab? What is your priority, or what are things that you want to get back to? Kind of establishing goals that we can all get on the same page with and move forward to working on those goals. But it does take a little while. Again, on the inpatient setting, it's kind of nice because you see these patients over multiple days. So you can ask different questions every day and kind of get to know them and their families as they come in. Jennifer, looks like you've got
Yes.
your hand up.
Yes, can everyone hear me? Okay. Thank you guys for leading this very interesting conversation. Um, I had a question about the comfort that women tend to report higher issues with their prosthesis. And from my like very uh introductory information about prosthesis is that like if you don't initially get training and adherence, like a lot of people stop using it and they opt for like alternative methods like wheelchairs. So I wonder if like is there like a higher ratio for like female patients to opt for alternative prosthesis, or is it generally in the patient population that we see like the gender difference between those two?
I personally haven't had a ton of experience with prosthetics yet or the limb loss community. I think Aya touched on this a little bit in her presentation, but there's some big biomechanical differences between females and males, just structurally that can impact it, and developing a really good relationship with either your prosthetist and your PM&R physician or whoever is kind of managing the residual limb as well as the prosthesis. Makes a really big difference in quality of life for patients. But I have also heard that, if it's not comfortable or it's difficult to use, yeah, the patient's not going to want to use the device. The prostheses that I've interacted with, especially the like initial ones before they get into the more fancy ones, they can be pretty heavy, and sometimes females just don't have muscle mass to move the prostheses, and it's kind of a pain in the butt. But those are the biggest things that I've seen personally. Otherwise, I can't speak too terribly much on that part. I haven't done much of it yet. I thought this was a fantastic discussion on, some considerations between different sex and gender, and things that we need to really be thinking about, whether that's with assistive devices, prostheses, or just rehab in general that we don't always think about because from physician side of things, we're concerned about their medical care and making sure that they're stable to be in rehab, especially in the acute setting. But all of these things really impact their ability to stay in rehab and their function outside of rehab. My kind of biggest takeaway, I think, is just developing the best relationship that you can with your patient and the community that the patient has, as well as your community of therapists and staff that you have around you, so that you're kind of bubble wrapping the patient before they go home with the best things that or the best support that they can have in all of those settings. So from the chat says, I think women are prescribed prosthetics less than men. Also, women sometimes report higher rates of body image distress related to limb loss. Prosthetic aesthetics, for example, cosmetic covers and high heel adaptable feet are that are limited. Yeah, that's a really great point. I think Aya mentioned in her presentation that women reported difficulty with clothing, and that's just some differences in clothing in men and women just out in the community anyways. It's harder to fit prostheses in some clothing. Oh, awesome. Okay. So this is something that Ian has seen in their practice.
Honestly, you're so welcome to unmute too and let us know further about your comments, because it's something that you're right, Dr. Ingram, that was something that was in my article, and it wasn't something that they said was necessarily statistically significant, but it definitely was a trend. I mean, when it came to male versus female people with lower limb amputations, there was a very small amount, I'd say, or a very small proportion of the male participants that reported issues with clothing, and it was a lot less of them that reported issues with just necessarily like not liking it because of not liking the prosthesis because of the appearance as compared to the female. So definitely something big there.
Let me tell you, I have had so many conversations about shoes with women with limb loss. It's a really interesting conversation that I thought I would never have in residency. But in practice, I actually talked about shoe shape, shoe sizes, how to fit a shoe more than anything else, partially because I'm outpatient, you understand. And so that's the patient bias. I'm not a limb loss specialist, and they just kind of find me here and there. And just from what I know, I think men tend to have a higher rates of getting fitted with the prosthetics. And just statistic wise, that's kind of what I know, what I heard, and what I've seen when I was training. I, partially also because of higher rates of trauma. When I was training, a lot of soldiers were coming back. So that was a lot of the combat injuries. And so, the largest rate causes of limb loss, of course, in the United States is dysvascularity, right? The vascular disease. But I think women still have less rates of dysvascular amputations than men still in the United States. I don't think that statistics have changed since I trained. Of course, I could be wrong. It's been a while I trained. So,
It's interesting too. My aunt has multiple sclerosis, and so obviously not a limb loss, but I know earlier in like probably 5, 10 years ago, she didn't even want to use a cane or use the shoes that were recommended to her because of aesthetic reasons. And, she's married and has kids, but that's still something that's on her mind. So I thought it was a really interesting presentation that you guys brought to the forefront. And as I thought about it more, I was talking with her, and she doesn't have a physiatrist that she goes to see. We're in a little bit of a rural area, so she doesn't have access to that. And then on top of it, she's worried about aesthetics. So she has struggled quite a bit with her progression of her MS. So it's interesting to hear that from Dr. Lee too about talking about shoes because it really is something that matters to people and you don't realize it until you have that personal experience. So great job presenting today, guys.
Do we have any more questions for the speakers? Dr. Ingram, Dr. Lee? Okay. With that, I'm gonna wrap it up. Thank you all for joining us tonight. I want to say thank you again to Aya, Nathaniel, and Kirti for creating such an amazing discussion, and Dr. Ingram for facilitating everything. And we hope to see you at the next research or rehab roundtables. And we hope that you will sign up for the next ones to be presenters. We can't wait to hear you present. See you again. Thank you. Have a good night, everyone.